Professor Cihabir, can you summarize your experience on CDTs and especially large bore thrombectomy devices, and can you provide a current perspective for status of CDTs, including large bore thrombectomy, and your expectations from upcoming trials?
Professor Kaymaz, thanks a lot for having me, and I'm very happy with the ATOM work that you're doing with the organization. I work at Emory University in Atlanta, and I've been involved in pulmonary thrombectomy for acute pulmonary embolism for a while now, for many years, and things have progressed in the meanwhile, have become really something mainstay in treatment of pulmonary embolism. At this specific moment, as opposed to the past, we're now able to remove a lot of clots from the lungs. We use it for patients at intermediate high risk when we're worried about them, tachycardic or breathing very heavy, desaturation, very bad RV, and they do very well. We improve the hemodynamics immediately on the table, and now we have good data on that. We have a large population study called FLASH and other studies that showed that doing thrombectomy on these patients improves the hemodynamics immediately, improves the PA pressure, the cardiac output. They breathe immediately better on the table, and the technology is now such that it doesn't take a long time to do it. It's relatively safe. The major complications in most of the studies we've looked at is significantly less than 1%. So that's the status right now. What's missing though is good, well-done trials, randomized trials, and now we're just starting to do that, and we're going to start seeing these. The first one of these that we're going to be seeing is the Peerless trial, which is large bore thrombectomy compared to catheter-directed lysis. Now, mind you that catheter-directed lysis has always been one of the accepted and widespread treatment options for pulmonary emboli. And the newest device that actually pretty good is the Bashir catheter pharmacomechanical thrombectomy that can reach the clots and dissolve the clots better than just regular catheter lytics. The interventional community has been using both the catheter-directed lytics and the thrombectomy devices. And so the first trial to be presented next month at TCT is the Peerless trial, which randomized patients to large bore mechanical thrombectomy versus catheter-directed lytics. And that's an important question for the interventional community to answer. We want to see what's the outcome in terms of mortality, escalation of care, deterioration of the patient, the usual endpoints that we'll look at in the PE trials. For example, the previous trial on lytics, this is the outcome that we'll look at. We're also looking at other things like ICU length of stay and readmission rate and total length of stay and a lot of factors. Now that's only the first set of trials, but at the same time now there are multiple trials ongoing, and these trials now want to answer the question, do we treat these patients or not? Do we just keep them on heparin and just treat them with thrombectomy? There's the Peerless 2 trial looking at catheter thrombectomy versus just anticoagulation with heparin or something else. There's also the PE-TRACK trial looking at the same question, but any catheter use versus just anticoagulation, with the outcome being a cardiopulmonary stress test at 3 months. You know, there's always this question about what to do with how are these patients going to do long term. So this study hopefully will answer that. I expect results from this study maybe in the end of 2025, maybe beginning of 2026. There's HI-PITHO trial, and I expect an answer from this trial at the end of 2025. HI-PITHO is looking at catheter lytics with Equus catheter versus anticoagulation. And there are other trials that now are in the making. There's actually a trial now that's going to just start at massive PD patients, high-risk PD patients treated with thrombectomy versus just standard of care like lytics or something else. Very exciting times, because now we're going to have more and more data and more expertise when it comes to treatment of pulmonary embolism.
Thanks. Can we learn your expectations for near future of the CDTs in acute PE treatment as recommended by future guidelines?
Yeah, so this is a very good question, because yes, as part of this community, we are treating the patients invasively, but the guidelines don't say that, right? So because the guidelines are using older data, on pulmonary embolism doing fine with just anticoagulation, but actually the patients are not always doing fine. There's still a finite mortality, 5% intermediate risk. The mortality of the high-risk patients is still at least 20% despite the treatments that we do. So we have to find something new. And the people writing the guidelines understand that. We're just waiting for more data. There's going to be new American Heart Association guidelines coming out in the next few months that will address these somehow. But it is important to note that by the time the guidelines are written, we will not have the results, the full results of all these trials going on. So there's going to have to be another follow-up in a year or so on the guidelines based on the results of these trials. My suspicion is that the interventional work, the interventional treatment of PE with catheter-directed therapy is going to appear more and more in the guidelines. It's going to be a cornerstone of therapy for PE together with the systemic lytics. So far, the guidelines say you just use the catheters if there is expertise and if the patient does not respond to something else. I bet that this is the catheter therapy is going to climb higher and higher in the guidelines as we see those coming up in 2025.
Thanks a lot, Professor Cihangir.